of these interactions, describe the adverse effects that result from polypharmacy and the resulting interactions in transplant, and recommend appropriate therapy or management of these common drug combinations. There was an interesting study performed by Gastaldi and colleagues out of Brazil that looked at the prevalence of drug interactions in transplant. It was a cross-sectional study in about 70 patients undergoing transplant over a 7-month period of time. About 66% of these patients received an allotransplant, 35% an autotransplant. The results were such that there was a median of 8 medications per patient. 60% of the patients had at least one potential drug interaction identified in their medication profile, and more than 20% had at least one potential major drug interaction identified. This major drug interaction is one that was considered life-threatening and/or required a medical drug intervention. There were 31 types of drug interactions identified of the 128 total, and to no one's surprise, cyclosporin was the most common agent identified in a potential drug interactions at about 28%. So first, to start out, we'll just review types of drug interactions that are out there, bring you back to pharmacy school, to the basics. The first is a pharmacokinetic drug interaction, and this happens when there's a change in drug and or metabolite concentration due to changes in absorption, distribution, metabolism, or elimination. The most common site for these interactions to occur are in the hepatocytes of the liver and enterocytes of the gut during CYP450 metabolism. The other type of drug interaction is a pharmacodynamic interaction, where you see a change in the physiologic activity of a drug. For example, you see an increase or decreased therapeutic effect of the drug, or an increase in adverse effect. An example of a pharmacodynamic interaction would be a patient that's on cyclosporin and on an aminoglycoside. The combination of both of these increases that patient's risk for nephrotoxicity, as these are both adverse effects of those agents. But for the remainder of this talk, I will be focusing only on pharmacokinetic interactions in transplant. So let's delve into the CYP450 superfamily that we all know so well. It's a group of enzymes in the liver, found in the liver, intestines, and kidneys, and it's responsible for decreasing or altering pharmacologic activity of drugs and assisting in their elimination. There have been over 50 genes identified within the family, but of these 50, only 7 genes are primarily responsible for a majority of drug interactions, including CYP1A2, 2B6, 2C9, 2C19, 2D6, 2E1, and CYP3A4. Not surprisingly, CYP3A4 accounts for about 50% of all CYP450 enzymes and is involved in more than 50% of all drug metabolism. There have been a number of polymorphisms discovered in the CYP450 superfamily, and a few of those I have listed there. These mutations range from slow and poor metabolizers to extensive and ultra metabolizers. An example of a poor metabolizers are those patients that have inactive CYP2C19 enzymes. This compromises about 25% of the Asian population and about 3 to 6% of the Caucasian population. And just as a review, drugs that are metabolized by 2C19, a few examples would be cyclophosphamide, proton pump inhibitors, and voriconazole, as Ashley pointed out in her presentation yesterday. So what kind of interactions, what are the mechanisms of the interactions that we see in the CYP450 family? Basically, inhibition and induction. Within inhibition, there are 2 main mechanisms for this interaction. First is direct inactivation of the enzyme by the inhibiting medication, and also competition between substrates of that enzyme. This results in increased drug concentration and prolonged half-life, as well as increased potential for toxic side effects. The onset is about 1 to 3 days, depending on the half-life of the drug, and the de-inhibition is about the same, typically 1 to 3 days. Induction mechanism the mechanism would be a decrease in the synthesis of the enzyme and/or an increased breakdown of the enzyme. This results in decreased drug concentration and decrease in elimination half-life, thereby increasing the potential for therapeutic failure. The onset and max effect is quite a bit longer in induction drug interactions. It takes about 1 to 2 weeks, and I apologize on my slide. It depends on the drug half-life, the maximum effect, and the degradation of the enzyme, which I have listed below. However, the de-induction as well takes weeks, and it depends on the drug half-life as well as protein synthesis of those enzymes that were broken down. First-pass metabolism after oral drug administration can be majorly affected by drug interactions. CYP enzymes in the intestine are more exposed to interacting drugs versus the hepatic enzymes. And as a result, the bioavailability and elimination of the drug can be dramatically increased or decreased. So this is sort of a pictorial, I hope you can see it well, of an example of a drug interaction that can happen with first-pass metabolism. So starting up here, this patient is taking a felodipine dose, 100% bioavailability, swallows it, goes through the stomach into the intestine. If you focus over here on the non-dotted line, the straight line, once it hits the enterocytes, it's metabolized by CYP3A4, goes from being 100% bioavailable to 30%. It then enters the portal vein and goes into the hepatocyte there, is further metabolized by CYP3A4 in those hepatocytes, and now goes from 30%, I can't see very well, I believe it's 15%. As such, only 15% of the drug is now systemically available to act within the patient. Now let's look at giving this patient the felodipine dose in the presence of a CYP3A4 inhibitor such as grapefruit juice. So the patient swallows the felodipine dose with some grapefruit juice, goes down, gets into the hepatocyte, gets into the intestines, and is now into the enterocytes. As you can see, the grapefruit juice inhibits the metabolism that is normally done by CYP3A4. So instead of only having 30% available after metabolism, you have 90%. It works its way over to the portal system. The grapefruit juice does not inhibit the enzyme at this point, so it does actually get cut in half, going from 90% to 45%. And that's what's systemically available to act within the patient. As you can see, this is a 3-fold increase drug availability for the patient, simply by taking grapefruit juice. P-glycoprotein is another mechanism or a pathway for drug interactions. So first, what is P-glycoprotein? It's a membrane transporter produced by the multi-drug resistant gene MDR1. Essentially, its original role was to act as an efflux pump to kick chemotherapy out of the cell, thereby making it less effective and the cancer resistant to this therapy. P-glycoprotein is located in enterocytes of the small intestine, hepatocytes, proximal tubules of the kidney, and endothelial cells of the blood-brain barrier. Although we know its original role was to decrease chemotherapy absorption and increase elimination, there are many non-chemotherapy medications that are metabolized through this pathway. Drug-induced inhibition of P-glycoprotein activity whereby the efflux pump is inhibited, results in increased drug absorption by enterocytes in the intestines and decreased drug elimination by the biliary and renal excretion. Interactions with P-glycoprotein is not a class effect. For example, within the calcium channel blocker group, diltiazem and verapamil are P-glycoprotein substrates, however, nifedipine is not. Additionally, you'll see that there are many agents that are substrates of P-glycoprotein and CYP3A4, but this is not an absolute list. This is just sort of another pictorial to show how the interaction happens. So anti-neoplastic drug you could replace with a non-anti-neoplastic drug, absorbs into the cell and binds to P-glycoprotein receptor and essentially gets kicked out and is eliminated from the body. However, in the presence of the inhibitor, it prevents this efflux pump from pumping it out of the cell, keeping it within the cell and causing its action. So we'll get to our first ARS question. Sirolimus is metabolized by CYP3A4 and P-glycoprotein. It also undergoes extensive first-pass metabolism. Ketoconazole is a known inhibitor of CYP3A4 and P-glycoprotein. What will most likely happen if these two drugs are administered together? A, the bioavailability of ketoconazole will decrease. The bioavailability of sirolimus will increase. The serum concentration of sirolimus will decrease. Or D, the serum concentration of ketoconazole will increase. All right. Okay, looks like we have a good majority of you have answered. And yes, correct. 86% of you got the answer correct at B. The bioavailability of sirolimus will increase due to the inhibition of CYP3A4 and inhibition of P-glycoprotein metabolism of sirolimus. So next we will sort of switch gears and start looking at different classes of drug interactions, classes of drugs that are commonly used in the transplant setting, first starting with chemotherapy. Mechanisms for drug interactions with busulfan are essentially twofold. First is competition with glutathione, and this is because busulfan is metabolized by conjugation with glutathione via glutathione S transferase catalysis. It also has a mechanism of drug interaction with busulfan is inhibition and induction of CYP3A4. This is interesting, however, because bu essentially undergoes oxidative metabolism, and there has not yet proven that CYP450 plays a role in its metabolism. Irregardless, some CYP3A4 inhibitors and inducers alter bu metabolism. Dr. Glatzbecker and colleagues from Dana-Farber published a really nice review in BBMT in 2012 of drug interactions in transplant. And I thought this was a really nice table going through busulfan-specific drug interactions. First, looking at acetaminophen. This is a theoretical-based drug interaction, knowing that there's competition for glutathione, which as a result could increase in busulfan serum levels. And these authors, as well as the busulfan package insert, recommends not using Tylenol with busulfan 72 hours before or 72 hours after busulfan has been completed. Itraconazole and voriconazole can lead to reduced busulfan clearance and resulting in increased busulfan serum level, most likely due to CYP3A4 inhibition. It's recommended to be used with caution, monitor for effects of busulfan. A lot of us are doing therapeutic drug monitoring. In our case, I would recommend avoiding both of these agents when you're giving busulfan and using anakinda candida if necessary, or possibly fluconazole, knowing it's not as a strong inhibitor. Metronidazole is a well-known drug interaction with busulfan, thought to be due to CYP450 inhibition and competition for glutathione. Leads to increased busulfan trough levels. This author and the package insert for busulfan is recommending not using metronidazole 72 hours before or after busulfan administration. Phenytoin as well is recommended not to be given concomitantly due to induction of glutathione S-transferase and CYP3A4, as this leads to decreased busulfan plasma concentrations by at least 15%. Jennissen and colleagues wanted to evaluate the concomitant administration of busulfan and metronidazole, and they did this in 24 allogeneic transplant patients. They separated these patients into 3 different groups. Group A received busulfan and metronidazole concomitantly for 4 days. Group B had busulfan alone for the first 2 days, and the next 2 days received busulfan with metronidazole. And Group C was essentially the control, where the patients received busulfan alone. This chart below just shows the mean concentrations, trough levels that were taken within each group. So our control down here with busulfan alone, mean trough level of about 507 nanograms per mil. If you compare that to Group A, where the patients were taking metronidazole and busulfan together, there's quite a significant increase in the mean trough level at about 950. B was looked at in 2 different ways. Remember, B, the first 2 days busulfan was alone. So this is the 2 days busulfan was alone. The trough concentration was about 452, which is comparable and not significantly different from C. However, when metronidazole was added on days 3 and 4, you can see there was a significant increase in the trough level when compared to the 2 days prior and compared to the control. This is essentially a chart showing you the same thing for those that like to have a visual view. This is comparing Group A, where the patients took busulfan and metronidazole together for the 4 days, compared to the control where they have bu alone. You can see the concentration of bu down below here when it was busulfan alone, and up top was the 2 together. My guess is that at this point they did a dose reduction of busulfan. As you can see, the levels are dropping and becoming more consistent with C. The second is looking at Group B and Group C, our control. Up front, the first 2 days, where both groups were just taking busulfan, they have very similar trough levels. However, in Group B, the next 2 days, they took metronidazole with their busulfan, and you can see that significant increase and change compared to the control group. So these authors looked at the regimen-related toxicity of these 3 different groups. Group A, 5 of the 5 patients all had increased liver function tests. 3 of the 5 were diagnosed with sinusoidal obstructive syndrome by Jones criteria. In Group B, 5 of the 9 patients had increased bilirubin, 1 with increased LFTs, yet no diagnosis of sinusoidal obstructive syndrome. In Group C, had 3 patients with elevated AST and no sinusoidal obstructive syndrome diagnosis. So these authors concluded that an increase in busulfan concentration may be due to decreased glutathione content, secondary to metronidazole reactive metabolite using glutathione as a scavenger. Additionally, the risk of sinusoidal obstructive syndrome may be due to high bu and increased metronidazole reactive metabolites. So moving on to cyclophosphamide. Cyclophosphamide is a substrate of several CYP enzymes, with the major being CYP2B6. And I'm not going to go through this, very complex metabolism pathway of cyclophosphamide. I have tried to do it before myself, and it just gives me a headache. But rather, I just put it here so that you could appreciate its complexity, for one. And you can see there are many, many avenues whereby drug interactions can occur in cyclophosphamide metabolism. As I said before, cyclophosphamide is a major substrate of CYP2B6, and you should consider alternative therapy if CYP2B6 inducers or inhibitors are to be given concurrently with cyclophosphamide. And I have a few of those listed there. DeJong and colleagues published a case report where there was a patient who was on cyclophosphamide and phenytoin concurrently. They did a pharmacokinetic analysis of the patient after this, and the results were such that there was a 133% rate of formation of the active metabolite 4-hydroxycyclophosphamide, or 4-OHCP, when given with phenytoin. There was also a 51% increase in the AUC of 4-hydroxycyclophosphamide and a 67% decrease in the AUC of cyclophosphamide parent compound. So basically, as many of you know, IV cyclophosphamide undergoes autoinduction to this active metabolite on its own without any drug help. But when you add phenytoin to this, it essentially speeds up this process. And that's why you see this increased rate of formation, increase in the AUC of the active metabolite. In this patient, subsequent doses were decreased by about half. No specific toxicities, thankfully, were observed. However, the authors concluded that you should avoid co-administration of phenytoin and cyclophosphamide due to this significant induction of cyclophosphamide metabolism. In another study by Dagamira and colleagues, they retrospectively evaluated cyclosporin levels in patients that had cyclophosphamide-containing regimens versus those that had non-cyclophosphamide-containing regimens. They evaluated 103 patients. Of those patients that had cyclophosphamide in their regimen, they all had the same cyclophosphamide dose of 60 milligrams per kilo per day for 2 days. And all the cyclosporin levels were evaluated while these patients were taking intravenous dosing. You can see on this top, I hit the wrong button here, scatter plot, there's definitely a difference in the cyclosporin levels on those that were taking non-cyclophosphamide regimens, significantly higher levels compared to those that had cyclophosphamide-containing regimens. Down below, this is more just a longitudinal look at the cyclosporin levels in those patients. The dotted lines were those patients that did not have cyclophosphamide-containing regimens and those that did have cyclophosphamide-containing regimens. And as you can see, this was taken out to 14 days, or day plus 14. So the effect lasted quite a bit longer after cyclophosphamide had stopped. The authors did a multivariate regression analysis and not only looked at the conditioning regimen, also looked at age, donor, and use of antibiotic to see if it had any influence on cyclosporin levels. However, cyclophosphamide-containing regimen was the only one found to have this significant influence. The authors' hypothesis and conclusions of this was that they hypothesized that the autoinduction of the hepatic enzymes by Cy that happens, or cyclophosphamide, including CYP3A4, may actually result in decreased cyclosporin levels. And this enzyme induction, as I had said before, can last for weeks at a time, which was evidenced by the longitudinal graph we saw in the previous slide. They also hypothesized that there may be cyclophosphamide may activate renal elimination of cyclosporin. However, there have been no published reports to support this theory. Hassan and colleagues studied a possible PK interaction between busulfan and cyclophosphamide in 36 patients. These were split into 3 groups. First group is cyclophosphamide TBI with patients not receiving busulfan. Second, it was a BUSI regimen where the first dose of cyclophosphamide was given less than 24 hours after the last dose of busulfan. With the third group receiving the same regimen, but the first dose of cyclophosphamide was given greater than 24 hours after the last dose of busulfan. The results of this study, when you look at group 2 compared to groups 1 and 3, and group 2 being where they received Cy less than 24 hours after the last dose of Bu, they saw that the clearance of cyclophosphamide was significantly lower. The half-life of cyclophosphamide was significantly longer, and sinusoidal obstructive syndrome was significantly higher and mucositis more frequent in this group. And they also found that there was a significant positive correlation between the concentration of busulfan and the AUC of 4-hydroxycyclophosphamide, which is the active metabolite of cyclophosphamide. These authors hypothesized that administering Bu prior to Cy puts patients at risk for Cy toxicity for the following reasons. As we know, Bu's main metabolic pathway is mediated by glutathione. We also know that cyclophosphamide's active metabolites, including 4-hydroxycyclophosphamide, eventually undergo enzymatic detoxification by glutathione. So, if you are to administer cyclophosphamide less than 24 hours after the last dose of busulfan, hepatocytes may be depleted of glutathione, and Cy active metabolites are then not detoxified. And they concluded and recommended that you should consider altering preparative regimens in terms of time and schedules and dose intensity in those patients receiving busulfan and cyclophosphamide. Moving on to etoposide, as you know, is a major CYP3A4 substrate in which you consider alternative therapy if CYP3A4 inducers or inhibitors are given concurrently with etoposide. I won't go through each one of these here. It's more for completeness sake, listing CYP3A4 inducers and inhibitors. Thiotepa also is a strong 2B6 inhibitor, and you should consider alternative therapy if CYP2B6 substrates are to be given concurrently with thiotepa. Fortunately, melphalan, fludarabine, and carboplatin have no significant PK drug interactions to appreciate. So our next audience response question: which of the following may result if rifampin is administered with cyclophosphamide? A, increase in the AUC of the active metabolite 4-hydroxycyclophosphamide. B, increase in the AUC of cyclophosphamide, the parent compound. C, decrease in AUC of rifampin. Or D, no significant change in the AUC of either drug. Okay, we have almost everyone, I think. Maybe a few are sleeping. Okay, correct. 77% of you are correct. The answer is A. There'll be an increase in the AUC of the active metabolite 4-hydroxycyclophosphamide. As I said before, cyclophosphamide is a major substrate of CYP2B6, and rifampin is a strong CYP2B6 inducer, leading to this result. So next we'll move on to the immunosuppressive agents. So this is a very busy list again, but cyclosporin and tacrolimus we know is extensively metabolized by CYP3A4 in the liver and small intestine. So of course they're at risk for potential drug interactions with strong CYP4 inducers and inhibitors. Cyclosporin and tacrolimus are also P-glycoprotein substrates. So again, there's this whole slew of lists of medications that have the potential to interact with the calcineurin inhibitors. I've highlighted in red those medications that are not only P-glycoprotein inducers and inhibitors, but also CYP4 inducers and inhibitors, just so that you can appreciate the overlap that you can see with these agents. I did include an appendix in your handout that will, the next few slides I'm going to go over, have a lot of charts on them. They're not very easy to see at all on a slide presentation, which is why I included them in the appendix, but we'll kind of muddle our way through it. This chart was taken from a nice review from our very own Helen Leather. She published in Bone Marrow Transplantation in 2004, and I know it's very hard to read, but this is just some clinically relevant PK drug interactions with cyclosporin, listing the drugs there, the proposed mechanism of action, clinical effect, and recommended action as a result of these. Some of these are theoretical-based reasons, but others come from case reports and PK studies. But as you know, a lot of you work with these medications every day. The beauty of it is that not only with cyclosporin and tacrolimus, we have the ability to check levels. They have very common adverse effects and side effects that we're very well aware of. So we know these drug interactions exist. There are many of them out there, but we have the ability to monitor them appropriately and just accordingly. This just continues on, also including the tacrolimus list. And Dr. Glatzbecker, I had mentioned him before, he also had a drug interaction review published, and so for completeness' sake, I wanted to include his chart with calcineurin inhibitors. Next, moving on to drug interactions with sirolimus. It's extensively metabolized by CYP4 in the liver and small intestine. So similar to the calcineurin inhibitors, there's a whole list of inducers and inhibitors that have the potential for drug interactions with sirolimus. The caveat and the tricky thing about sirolimus, as you know from those of you that have worked with it, is it's a very, very long half-life. About 62 hours plus or minus 16 hours. So knowing when the drug interaction can occur, at what point you should dose reduce, dose increase, can be delayed and very tricky and hard to work with. Again, just to make things interesting, it's also a PGP substrate, so it has the risk or potential for drug interactions with P-glycoprotein inducers and inhibitors. Again, I highlighted those in red that are also on the list of the CYP4 inhibitors and inducers. I also included an Appendix 2 in your handout that will include the few charts I'll go over next. Dr. Glatzbecker put in a nice chart going through the sirolimus drug interactions, again alluding to the drug, the mechanism, the data. A lot of it is case reports, PK studies, what the effects are, and the recommendations. A lot of it, again, with sirolimus, similar to calcineurin inhibitors, we have the beauty of following levels. So that's very helpful to know what kind of impact these drug interactions have. But again, you always have to keep in mind that when you change a dose, it may be 3 to 4 days before you actually see the effect of that change, which can be hard because I know myself, I'm very antsy to see the change, and we just have to remind ourselves that something could still happen. Zimmerman and colleagues evaluated the optimal timing of cyclosporin and sirolimus administration in 24 healthy volunteers. So these volunteers took a dose of Neoral, 300 milligrams, along with 10 milligrams of sirolimus oral suspension, and then had a series of drug levels drawn. So in those patients that took sirolimus at the same simultaneously with cyclosporin, they saw sirolimus Cmax increase by 116%, and the AUC increase by over 200%. Then they looked at those that took sirolimus 4 hours after the patient or the volunteer took cyclosporin. And the Cmax was only increased by 37% and AUC by 80%. And that's shown here on top. The top one is where the patient took sirolimus with cyclosporin. As you can see, the top line is different from the one on the bottom, where it was sirolimus alone, and in the middle was 4 hours after. This chart here just shows that cyclosporin was essentially unaffected by the administration of cyclosporin and sirolimus together. So these authors concluded and pondered why does this happen? Why does cyclosporin increase sirolimus bioavailability? And they hypothesized that this is possibly due to P-glycoprotein substrate competition. There's P-glycoprotein and or CYP3A4 inhibition by cyclosporin, and or greater P-glycoprotein and CYP3A4 affinity by cyclosporin. So they recommended administering sirolimus at least 4 hours after cyclosporin and consider sirolimus dose reduction. And these recommendations are similar to what is in the sirolimus package insert. Cathryn and colleagues performed a similar study looking at it in 24 kidney transplant patients and essentially had the same results. However, there was a PK study by McAllister looking for this effect with tacrolimus and sirolimus and did not see the same effect. So it seems to only be unique to cyclosporin and sirolimus. Looking at sirolimus and drug interaction with voriconazole, Marty and colleagues evaluated the co-administration of sirolimus and voriconazole in 11 allogeneic transplant patients. 8 of the 11 patients decreased their sirolimus by 90% prior to voriconazole initiation. And those 8 patients are those not listed in yellow. As you can see, the sirolimus dose before vori, for example, was 2. The adjustment decreased by 90%. Their level before, 7.4. Afterwards, a little bit higher, but not significantly different. And you can go through each line and you see about the same in regards to levels. However, patients 4, 10, and 11 decided they weren't going to reduce their sirolimus dose, and there was quite a significant change in their level. Dose before was 2 milligrams. Dose adjustment did not have one, it remained at 2 milligrams. Sirolimus dose before was 4.5, and their sirolimus level after voriconazole administration was almost 30. And you can see some same results down on patients 10 and 11. So essentially, there was a 3 to 5-fold increase in the sirolimus level when voriconazole was administered. Fortunately, no significant adverse effects were reported. So the authors concluded that voriconazole strongly inhibits the metabolism of sirolimus mediated by CYP3A4 and P-glycoprotein. So they recommended that an empiric 90% dosage reduction in sirolimus and frequent monitoring of sirolimus levels. Because I work in pediatrics, I have to give my pediatric plug here. We have patients that are on sirolimus, but as with all peds, our doses are a lot smaller. So if we were to initiate voriconazole and they tell us to reduce the dose by 90%, it's virtually impossible to do that because their doses are already that small. We've looked into possibly getting a more dilute solution of sirolimus, but we've been told thus far that that's not possible. So with our pediatric patients, and maybe with some of you out there that have pediatric patients that you work with, If our patients are on sirolimus, we 100% avoid voriconazole altogether. And we put our patients, typically the patients we have on sirolimus are at risk, high risk for mold infection, so a majority of them are on echinocandins, which is somewhat unfortunate as it's an IV product and they basically have to take it for a good 3 months. So moving on to other immunosuppressive agents, mycophenolate, there's some literature out there that has shown that cyclosporin can inhibit mycophenolic acid, which is the active metabolite of MMF. It inhibits its intrahepatic recirculation, resulting in decreased MPA-AUC. And so the MMF dose may need to be adjusted if cyclosporin is started or stopped, and or looking for adverse effects of MMF if CSA is started or stopped. However, this same interaction has not been seen with tacrolimus or sirolimus. We know that methotrexate is a very well-known drug interaction with other antifolates and is an absolute contraindication to administer these agents together, such as Bactrim. Giving them together could lead to some serious adverse effects from methotrexate, such as very severe bone marrow suppression and even reports of death in patients. So although it is a very well-known interaction, the PK interaction has yet to be fully identified as to why this happens. So on to our third question. Concomitant administration of phenytoin and cyclosporin puts the patients at most risk for which of the following events? A, breakthrough seizures, B, cyclosporin-induced hypertension, C, relapse of malignancy, or D, graft versus host disease. Okay, it looks like a majority of you answered. Okay, very good. Almost a little more than half of you got the correct answer, graft versus host disease. And the reason for this is cyclosporin, as I mentioned before, is a major substrate of CYP3A4. If you give it with phenytoin, phenytoin is a very known strong CYP3A4 inducer. This could lead to decreased cyclosporin plasma levels in your patient, and we all know that low cyclosporin plasma levels could potentially put the patient at risk for graft versus host disease. So moving on to antimicrobials. Luckily, being that everything else we've talked about thus far has 1,000 drug interactions, there aren't too many to talk about with the antibiotics used in transplant. Fluoroquinolones, as many of you know, the absorption can decrease when co-administered with medications containing divalent cations. Examples of these are medications that include aluminum, calcium, magnesium, iron, not listed on here, but another pediatric plug, a lot of them are in tube feeds, so that's something that we have to think about. And we all know that a lot of our transplant patients are taking medications that include these agents. So it's important to administer fluoroquinolones at least 2 hours before or after ingestions of these products. Metronidazole, as I had mentioned before, increases busulfan trough levels by CYP3A4 inhibition and glutathione competition, and concomitant administration of the two should be avoided. It can also increase cyclosporin and tacrolimus levels by CYP3A4 inhibition. As a result, careful monitoring of cyclosporin and tacrolimus levels and adverse effects should be monitored. And then there are the antifungals. Also, a class of agents that has the potential for many, many, many side effects. So first looking at the azoles, I've took each drug within the class and just listed the pathways for their metabolism and the potential pathways for drug interactions. And as you can see, there are just a few for each one. My next few slides, again, I have some charts in there taken from the reviews that I've already spoke of, but we'll go through those here. Sorry, I know that's probably very hard to read. The good thing that although there are numerous drug interactions seen with the azoles, there are well-established recommendations for what to do with most of these interactions. The top chart here is looking at the azoles when given with the calcineurin inhibitors and sirolimus. And this is taken from Dr. Glatzbecker's review, and he gives some pretty concrete recommendations on how much to dose reduce and dose reduce both agents and what to follow in regards to that. And again, I'll let you look through these on your own time. I know that it's hard to read from where you're at, and you're probably familiar with many of them, and this would be a 5-hour talk if I went through each one. So, drug interactions with antifungals continued, looking at echinocandins, including caspofungin and mycofungin. So in caspofungin and cyclosporin, there were 2 adult studies that evaluated the concomitant administration. And they found that there was about a 35% increase in caspofungin AUC when administered with cyclosporin, and transient increase in LFTs. Some evidence suggests that this interaction occurs due to the fact that cyclosporin inhibits the uptake of caspofungin into hepatocytes. And the caspofungin package insert recommends that concomitant administration is not recommended unless benefit outweighs the risk. And I don't know about any of you out there that have used these 2 agents together, but at our institution we used to give them together all the time. We certainly saw patients have elevated LFTs, but that can happen with caspofungin alone, not in the presence of cyclosporin. In those cases, we would dose reduce the caspofungin if necessary, or we'd switch to another agent. So while I appreciate that there may be some drug interaction potential, I'm not sure that it's warranted as an absolute contraindication to give them together. Caspofungin and tacrolimus, when studied in healthy adults, showed a decrease in tacrolimus AUC by about 20%. But luckily, again, any interaction with a calcineurin inhibitor, at least you can follow levels and adjust accordingly. Mycofungin, which now is our echinocandin of choice, luckily, because it is a weak CYP3A4 inhibitor and has no significant PK interactions that have been reported. Touching quickly on the antivirals, there's really not much to say. There's no significant PK drug interactions reported with acyclovir, valacyclovir, ganciclovir, valganciclovir, and foscarnet. The only one to really note was cidofovir, and it's not necessarily cidofovir itself, but with probenecid. It is recommended that probenecid is given with cidofovir to reduce nephrotoxicity induced by cidofovir, but co-administration of probenecid and meropenem can result in over a 56% increase in meropenem AUC. So, and this is thought to be due to the fact that probenecid competes with meropenem for active tubular secretion. So the co-administration is contraindicated according to the meropenem package insert. So our final question of the day. RA has started myeloablative conditioning with Bu-Cy-TBI for his matched unrelated donor transplant. His Clostridium difficile culture just returned positive. What would be the best course of treatment? A 10-day course of IV or oral metronidazole. B, a 10-day course of oral vancomycin. C, a 10-day course of IV vancomycin. Or D, a 10-day course of IV metronidazole and oral vancomycin. most of you have answered. Very good. 88% of you correct. The correct answer is B, a 10-day course of oral vancomycin. As I mentioned a few times already in this talk, avoiding metronidazole and busulfan due to the drug interaction is important. And as we all know, as very good pharmacists, that IV vancomycin is not indicated for Clostridium difficile treatment. So adverse effects of polypharmacy and drug interactions. The patients that we all take care of every day, they're on more drugs than most types of patients that we see out there. So the fact that there's a lot of drug interactions is really no surprise. So we always have to think of what are the results of these? What are the results of the polypharmacy that these patients are having to undergo? And toxicity and or treatment failure are probably the biggest concerns. So looking at chemotherapy, toxicities that could be a result of a drug interaction include myelosuppression, sinusoidal obstructive syndrome, and mucositis. And of course, treatment failure, which would probably be the worst of all, malignant disease relapse, autoengraftment of their own cells. Within immunosuppression, well-known toxicities that may result from a drug interaction include myelosuppression, malignant hypertension, nephrotoxicity, PRES, loss of the graft, or treatment failure resulting in graft versus host disease or lack of engraftment. Antimicrobials, we know common toxicities of nephrotoxicity, ototoxicity, superinfections, and of course treatment failure where the infection itself is not eradicated. So these are all things that we have to think about and consider when we're encountering a drug interaction and what to do with that. So my recommendations and conclusions to you that work with these patients every day and have to go through and identify these interactions is to do a medication profile evaluation every single day. I know myself, sometimes I see these patients, I work mainly inpatient, but you go through their list every day, and it can seem to get monotonous and you kind of forget some stuff, but you just have to make a mental note of things that may have stopped in the middle of the night that could now lead to a drug interaction because you adjusted for the fact that it was on before. Closely monitoring drug levels when an interacting medication is started or stopped. I know that's something we always have to kind of beat into our students and into our residents. They're really good about thinking about when a medication is started and there's a drug interaction, but they seem to forget what happens when the medication stops. So that's something that we have to constantly remind them. Of course, assessing for adverse effects when an interacting medication has started or stopped. And of course, I know you all are very familiar. There's many drug interaction tools and websites out there that can guide you, and I have those listed here. Also, empirically, altering dosage regimens when applicable, finding alternative therapy if it's contraindicated, are all things that we can do to help with our patients to avoid adverse effects with these many, many drug interactions. So with that, take some questions.
Hi, Kathy. That was a great review. I do have a quick question, and I don't know if there's really one singular correct answer, and maybe some of the people in the audience can chime in on this. We went into the question of, for the few patients that may be on TPN at the time that they're receiving methotrexate for their graft versus host disease prophylaxis, how do you handle the multivitamins in relation to the administration of methotrexate? I guess that is when you can find and obtain the multivitamins.
Yeah. Very true. Yes, and of course, with dealing with a pediatric population, almost every single patient we deal with is on TPN at some point during their hospital stay. I will say not many of our patients actually receive methotrexate, but knowing that the folic acid or the multivitamin could possibly render the methotrexate somewhat ineffective, although They're probably minimal doses that we're putting in the TPN, but why run the risk of that potential drug interaction? If we have a patient in that way, we usually give it on methotrexate on days 1, 3, 6, and sometimes 11. During that time, I would just avoid putting it in the TPN and just add it after therapy is over, maybe waiting at least 24 to 48 hours after methotrexate is complete, just to avoid that potential risk.
I was just curious, with sirolimus, when you have a drug interaction, it says more frequent monitoring of the level, but with the long half-life, what's the recommendation for how often? Oftentimes our physicians are in the ICU putting in daily levels, and there's not a strict reference we can find that says anything in particular, but daily seems sometimes a little excessive. So do you have a recommendation for how often to check?
Yeah, that's a great question, and we question this ourselves. Typically, if we make a dosage change or we are just starting sirolimus, we want to wait at least 2 to 3 days before we'll check a level. With that said, we've had patients that we've added an interacting medication with, and the physicians have felt very strongly about checking daily levels, mainly to follow a trend. So if they feel strongly in doing that, I don't often balk at it, but if they see that it's going up and we just made the change yesterday, I'm like, okay, that's fine. It's going up, but we're not going to make a dose change. The next day it's going up, okay, we're still not going to make a dose change. So just make sure that they realize that, yes, if you want to closely follow levels, especially in a patient that's really sick, or a patient where you're worried sirolimus is only given orally, you're worried about absorption, they want to follow it daily, I'm fine with that, as long as they realize that they shouldn't be making changes every single day based on those levels.
Yeah, that's what we've been struggling with, the education piece, so it's good to know we're not alone.
Yeah,
Thanks.
good. All right, thank you very much.